Hello, we are going to talk about stoma and peristomal skin conditions. We have early complications and late complications. First, let's start talking about early complications. We have the ischemic necrosis. As you see here, this is an early complication within 24 hours. And it is happening because of the surgical technique. How to avoid this ischemic necrosis? First, avoid tension on the mesentery and avoid ligation of the primary blood supply to the stoma segment, and avoid excessive dissection of any mesentery because the mesentery is carrying the blood supply of the stoma. We have other early complications, two types of dermatitis. Allergic contact dermatitis, which is a product hypersensitivity. Like you see here, it is a broad redness and it will be itchy for the stoma patient. And our treatment involves removal of the allergen to avoid the occurrence of allergic contact dermatitis. So the product itself is the cause. So you can do a patch skin with other products as needed. And by the way, you can also liaise with some dermatologists for multiple allergies and further management. We have another type of dermatitis called irritant contact dermatitis due to leakage of the chemical substances of the intestine under the pouching system to the skin. So, as you see in front of you, this is a type of leakage. So how to do avoiding this? You have to review the product usage. You might use it wrong. Inappropriate sizing will lead to further leakage. And you have to liaise with some stoma nurse to adjust the pouching system. We have another type called peristomal bioderma gangrenosum. It is severe, irritant, and painful to the patient to have ulcer around the stoma skin. We have some types of treatment like alginate dressing, and we have waiver type skin barrier. Parastomal hernia, it is the most commonly associated with colostomy, not ileostomy, and it is a bulge around the stoma, and it is a true loops of intestine. Why? Because the fascial defect around the stoma is too wide and the intestine went through this fascial defect. Why? Because maybe the stoma location is selected by mistake, means that the stoma placed outside the rectus muscle, increase the intra-abdominal pressure with lifting or straining, and or defect in the abdominal musculature or loss of muscle tone, excessive large fascial defect, as we said before, and the placement of a stoma in a midline incision. Lastly, associated wound infection. All of these will lead to, as you see here, this is a parastomal hernia proper. And as you see in front of you, this is a true parastomal hernia, and it is massively appreciated in front of you. We have research in parastomal hernia treatment. One of them is to avoid occurrence of parastomal hernia, and we will talk later about the types of conservative non-surgical treatment, but we have some indications for surgery in parastomal hernia. So this is a hernia. So as with any other hernia, the indications are if obstruction, incarceration, strangulation, any perforation, ischemia, or any fistula formation. These are absolute indications for surgical intervention. Other relative indications include any intermittent obstruction, incarceration, pain, or any difficulty in a stoma care, or any associated skin conditions like ulceration. In general, patients with severe comorbid disease, extreme comorbid means severe obesity, end-stage malignancy, or any disease led to short life expectancy. So in this, we do not warrant repair of these parastomal hernia unless the current complication is life-threatening. Surgical repair, we have three options. Primary local fascial repair, as you see in front of you. Relocation of the stoma to the contralateral side with repair of the hernia. This is a second option. A third option is prosthetic mesh, either laparoscopy or open. And no trials, randomized controlled trials, talked about comparison of these three options of surgical repair. There is one non-randomized control trial talked regarding the high recurrence rate after the primary tissue repair, with a higher incidence of surgical wound infection. So non-surgical, like flexible pouching system, discontinuation of stoma irrigation, elective surgery may be indicated depending on the patient's comorbidities and after analysis of risk-benefit ratio. We have another option, as we told you before, but emergency surgery is required for non-resolving bowel obstruction and incarceration. And mesh repair is considered the standard surgical treatment for parastomal hernia, and we have many options: onlay, sublay, or open intraperitoneal. In the laparoscopic approach, the Sugar-Baker technique has a lower recurrence rate than the keyhole technique, and this is advanced type of surgeries for you. So this is a repair with a prosthetic mesh, underlay means under the fascia, and this is called a Sugar-Baker technique. And the other type is prosthetic mesh, underlay, but keyhole technique. We have papers talking about the parastomal hernia that the recurrence will be higher in obesity and wrong location of the stoma and the defect size of the abdominal wall. Another paper talking about prophylactic mesh use during primary stoma formation to prevent parastomal hernia. So using a mesh is prophylactically done to prevent the occurrence of parastomal hernia, And we have the European Hernia Society talked regarding the guidelines on prevention and the treatment of the parastomal hernia in 2019, and there is a high quality level of evidence supported the use of a prophylactic mesh during construction of a permanent end colostomy in elective surgery in reducing the incidence of parastomal hernia. And this level is strong, so it is strongly recommended to use a prophylactic synthetic non-absorbable mesh when constructing an elective permanent end colostomy for reducing the parastomal hernia incidence rate, but not recommended for the use of a prophylactic mesh for ileostomies or ileal conduit stoma, and no recommendations for the use of synthetic absorbable or biological meshes. We are going to talk about stoma prolapse and other types of stoma complications for the next time, and we hope that this lecture finds you well. Thank you very much.